Thank you, Dr. Gleaden. Good morning, everyone. Why have I chosen to do this talk? Well, in my time here since June, I've seen and managed more patients under an intermittent androgen deprivation therapy regimen for prostate cancer than what's certainly been the practice and experience I've had at home in New Zealand through my training. Certainly familiar with it, as I touched on earlier, but it wasn't as sort of common a practice. And so this sort of difference prompted me to think for this, or to explore this topic as part of this Grand Rounds presentation. So I set out with the aim of answering these questions with the presentation, really to look at what is the evidence base and rationale for ADT, what patients are best suited and how do you do it. And then in today's space of the novel hormonal therapies and the androgen receptor pathway inhibitors, where does ADT fit? So this graphic here, or schema, really just demonstrates the principles of an intermittent androgen deprivation therapy. A patient who is identified as requiring or having indications for commencing ADT begins a course of androgen deprivation, commonly called a run-in, where and then after a variable period of time, they're assessed of whether they've had an appropriate response or not to hormonal therapy. And if it's felt that they're primarily in the form of a PSA decline have achieved threshold, they will go on to a period of off therapy or intermittent hormonal therapy. During this off period, they'll then be followed clinically, possibly radiologically and with PSA, and until at some time point that they will meet triggers to then recommence androgen deprivation. And the idea that they'll carry on in this loop until some time point they may need to go on to a continuous ADT pathway or additional therapies. So a bit more, why have I looked at this topic, and why was intermittent androgen deprivation initiated or looked at in the first place? And so certainly, way back since the 1940s with the initial work, and in the last few decades, ADT has been the standard of care for men with advanced prostate cancer. That being said, we all know that it's associated with potentially significant morbidity and impacting patients' quality of life through various components, be it sexual, endocrine, cardiovascular risks, and just general quality of life, mood, physical capacity, etc. Another component, ADT, can certainly be expensive for either the patient or the healthcare system, the administration of the drugs, and the cost of the drugs themselves. An extra layer was really that from preclinical and early phase clinical trials that we'll go into shortly, there was evidence that suggested that intermittent therapy might actually offer benefit in prolonging the time to castration resistance compared to being on continuous androgen deprivation. There was lab evidence from animal models that suggested that this re-exposure to androgens after a period of androgen deprivation or ablation maintained hormonal responsiveness. And there was a number of preclinical trials in phase 2 and then 3 studies that showed that both intermittent ADT is feasible and could reduce some of the toxic side effects of hormonal therapy. So I've chosen to do this topic, and it's a bit of a sort of gulp moment when you're doing it, deciding to do a Grand Rounds talk, and you start doing some research and realise that some of your audience include the investigators behind the major evidence base on a topic. So I came across a few papers, regularly featuring the name of Goldenberg and Gleave, but this paper here was sort of part of Bruchowski's group, the lab studies that used an androgen-dependent, forgive the pronunciation, but Shinogi mammary carcinoma in a mouse as a model to suggest that castration followed by re-exposure to androgens before tumour progression preserved the androgen dependence and the surviving stem cells in the tumour and left them more amenable to further androgen withdrawal. So you could then do successive castration and re-exposure to androgens in this mouse model, and it was felt to produce multiple apoptotic regressions and roughly tripled the time to development of androgen dependence. So this cycle of androgen deprivation followed by re-exposure to testosterone is what's formed the basis of intermittent androgen deprivation in clinical practice. Following on from that lab-based work, there's subsequent phase 2 trials in the mid-90s with authors Goldenberg and Gleave involved, where they tested in the clinical setting the feasibility of intermittent therapy in treating prostate cancer. This series of papers looked at 47 men with advanced prostate cancer, where therapy was initiated with combined androgen blockade and continued for at least 6 months until a PSA nadir was reached. They then withheld therapy until the serum PSA increased to a value on average between 10 and 20, and the cycle of treatment and no treatment was repeated until the PSA progressed, demonstrating androgen independence. So the group saw that the first 2 treatment cycles, the group of patients had a mean time off therapy of between 30 and 33 weeks, and that patients actually had an average percentage time off therapy of between 40 and 45%. And they saw a return of the serum testosterone to within the normal range in around 2 months after stopping treatment. They importantly saw that during these times off treatment, the patients experienced an improvement in a sense of well-being and recovery in some of their sexual functions such as potency and libido. And this was in the men who had previously abnormal or near normal testosterone levels. So they concluded that they had demonstrated that it was feasible, it was safe, it did improve the quality of life of patients on this therapy, but really what was needed now was randomised trials to show was there a survival benefit. So there were subsequently a number of randomised controlled trials performed in the late 90s and 2000s to answer this question of whether intermittent therapy resulted in any difference in survival or time to castration resistance compared to continuous therapy. The individual trials and meta-analyses all had relatively similar findings, and here I'm going to present what I take to represent the 2 major trials in this space. So the first was the non-metastatic recurrent prostate cancer, so prostate cancer recurrence after local therapy. And this trial is a Canadian-initiated non-inferiority randomised controlled trial, which assessed the overall survival of intermittent versus continuous therapy in patients with a PSA recurrence without radiographic evidence of metastases at least a year or more post-radiation, be it primary or salvage. So listing some of the details of the paper here, the primary outcome measure was overall survival. They included secondary outcome measures of quality of life, time to castration resistance, and how long the patients had in their non-treatment intervals. They enrolled patients from 1999 to 2005. These patients had to have a PSA more than 3, more than a year since radiation, a pre-androgen therapy testosterone level of more than 5 nanomoles a litre, and no metastases on conventional imaging. Their run-in period was that they had 8 months of an LHRH agonist combined with 4 weeks of initial anti-androgen. And at the end of this 8 months treatment cycle, they went on to a non-treatment interval if there was no clinical evidence of disease progression and the PSA had gone below 4 and was also not more than 1 nanogram per mil above the last recorded PSA value in that treatment interval. Once they were off treatment in the intermittent arm, the PSA was monitored every 2 months until it reached 10, and also that they needed to have no clinical evidence of disease progression. Once the PSA reached 10, they then went into again an 8-month cycle of ADT, and if at the end of that period their PSA had responded appropriately, they came off therapy again. So looking at the characteristics of the patients, the 2 patient groups, the continuous versus intermittent therapy, was similar. Both groups were predominantly older men with median age of, we've lost it there, in their sort of early mid-70s, with lowish PSA, sort of 3 to 15, and most had more than 3 years since their radiation. So they enrolled just under 1,400 patients had a median follow-up of 6.9 years. The findings, there was no significant between group differences in adverse events. In terms of their primary outcome, they found that there was non-significant differences in overall survival between intermittent androgen and continuous therapy. Overall survival being 8.8 and 9.1 years on average between the two groups. And this met their definition for non-inferiority, and the trial was actually stopped early at a pre-planned interim analysis after intermittent therapy had met the pre-trial requirements for non-inferiority. So that was the overall survival. There were, again, a difference seen in the prostate cancer-specific survival, but it didn't reach statistical significance. Interestingly, majority of deaths were for non-prostate cancer related, 60%. The time to castration resistance was seen to be shorter in the continuous androgen deprivation arm. Interestingly, in the paper, the authors presumed that this difference was due to there being a delay in the identification of castrate resistance in the intermittent arm, where for the intermittent arm, they needed to have restarted their androgen deprivation and then have at least 3 PSAs before it was met the definition of androgen independence or castrate resistance. And I thought this was interesting, rather than sort of suggesting that it might be anything to do with, like that suggested in the lab model from Brigitte Prokowski, that it was more of a detection delay from the study. So other features, as expected, the men in the intermittent group had significantly less time on androgen deprivation, roughly a third of the time of the continuous group. In the intermittent therapy group, there was full testosterone recovery back to their baseline level in about 35% of patients only, and about 80% of patients achieved a testosterone level above the trial entry threshold of 5. Some Cox regression modelling showed that patients who are older than 75 were less likely than younger patients to have a return to their pre-treatment testosterone level. In terms of some of the quality of life things, interestingly, about 30% of men who were potent at baseline had a recovery of potency off therapy. In terms of the quality of life questionnaires, they all favoured, in all domains, favoured intermittent therapy, but the only domains reaching statistical significance were for hot flashes, sexual desire, and urinary symptoms. So what do I take from this trial? This is in the biochemically recurrent but non-metastatic space. Intermittent therapy in this trial is demonstrated to be non-inferior to continuous therapy. It results in clinically significant reduction in the duration of time on androgen deprivation, also with improvements in quality of life. I think also the question I took out from this trial in this patient cohort is the trial signalling that we should be very judicious in who we commence on androgen deprivation at all, versus, and is in a group continued observation quite appropriate. So moving into the second paper in a slightly different space, it's the role of intermittent therapy in metastatic prostate cancer. To date, the largest randomized trial is the SWOG 9346 trial, where it looked at intermittent therapy versus continuous therapy in the metastatic space. This was a randomized, again, non-inferiority trial, continuous versus intermittent therapy in castrate-sensitive metastatic prostate cancer, a similar time period in the late 90s through to 2008. Patients needed to have a histological diagnosis of prostate cancer, radiological evidence of metastases, good performance score, PSA more than 5, to meet enrollment, and then to meet randomization criteria, they needed to have a PSA that dropped below 4 after initial androgen deprivation therapy. Again, they had a run-in period, this time 7 months, LHRH agonist plus anti-androgen. And and then men who responded adequately to this run-in period with PSA dropping to below 4 were randomised to continuous ADT versus stopping at that time point and being managed with androgen intermittent therapy. The study prior to randomisation, patients were stratified by performance status, but also interestingly metastatic burden, where they had minimal versus extensive disease cohorts, minimal being metastases limited to the spine, pelvis, or lymph nodes, extensive being in the ribs, long bones, or visceral organs. So in the intermittent arm, patients again went into an off cycle. They were monitored with blood test, PSA, and also clinically every 3 months. The triggers for restarting ADT in this group was slightly higher, PSA of 20, or getting back to their baseline PSA, and also that if they if the PSA was rising in that first 3 months after going on to intermittent therapy, then even if it hadn't met those triggers of 20, they were transferred onto continuous ADT. And then they looked at the overall survival and quality of life with their own SWOG quality of life questionnaire. Some comments on the design, it becomes relevant later when we look at the statistics. They had designed the trial on the basis of data from previous SWOG trials, assuming that the median survival for patients with metastatic disease and continuous therapy would be about 35 months. The investigators felt that if there was a difference in median survival in the intermittent group, 7 months or more shorter than the continuous group, that this was clinically unacceptable. So they designed the study around the null hypothesis of non-inferiority with a hazard ratio should be less than 1.2, and powered the study to that. So they enrolled just over 3,000 patients. Half the patients roughly met the criteria for going into randomisation. Looking at the data for the whole enrolled population, I think is useful for us when we, in our clinical practice, counselling patients. You saw that for all comers who commenced androgen deprivation in this metastatic hormone-sensitive space, they had an overall survival of 3.7 years. But if your PSA didn't drop below 4 after 7 months, the median survival was just 1.7 years. Baseline characteristics, the groups were broadly equivalent. Median age is 70, with a 50-50 split between extensive and minimal disease burden. Predominantly low to intermediate grade cancers, Gleason 6s and 7s, and the majority was de novo metastatic hormone-sensitive prostate cancer. Interestingly, only about a third of those who met the threshold for randomisation actually got a PSA below 0.2. So we're seeing most patients who entered randomisation had a PSA 0.2 to 4. So what do we see in the primary outcome of overall survival? The intermittent therapy group lived 7 months less than the continuous group, but this was felt, and this is an interesting statement, felt not to be statistically inferior nor statistically non-inferior. So the hazard ratio there for death for intermittent therapy was 1.1 with a confidence interval of 0.99 but up to 1.23. So it both crossed 1 but also over the pre-planned hazard ratio threshold of 1.2. So, and so while the hazard ratio estimates favoured continuous therapy for prostate cancer specific site survival, not just overall survival, that they again were not statistically significant. So I think the median survivals there for both group of over 5 years was much better than that initially hypothesised at the trial design stage. And so this much improved overall survival perhaps has impact on the power of the study to detect difference in terms of their that they actually need more patients than what they planned for. difference to this study compared to the earlier non-metastatic space, the deaths in the study, the majority were due to prostate cancer. So in the continuous group, there was 73% of deaths were due to prostate cancer, 80% in the intermittent group. So looking here on the subgroup analyses, for SWOT, there's no hazard ratio shows statistically significant differences. Other outcome measure quality of life. So at 3 months after the randomisation, so this is where they've had their 7 months of hormone therapy and then go on, the time point 0 is the moment they either step into intermittent therapy or stay on continuous. So 3 months, so the expectation that all these patients in the intermittent arm are now off therapy, which is probably a subtle difference to the earlier trial where there was question marks of where this quality of life studies being done in the intermittent arm when they were actually back on therapy. But in this trial, at 3 months, the quality of life assessment in the intermittent therapy group were found that the intermittent group were significantly less likely to have impotence. They were more likely to have better mental health, and the scores for libido favoured intermittent therapy, but not at the pre-specified significance level. Then at further time point, 9 months after the randomisation, 4 out of 5 of the quality of life outcomes favoured intermittent therapy, and then this was started to wane by 15 months, where only physical functioning scored higher in the intermittent group. These differences that are at 9 and 15 months all didn't meet the pre-specified significance level. I think there's certainly a signal there that it's better quality of life, particularly when they're off therapy, as we'd expect. So from a statistical perspective, this was a slightly complex one to chew through, but and I summarise it, or I've included a statement from the paper there. It's both not inferior, but it's also not non-inferior, was the confusing statement. My take-homes, so this largest prospective randomised trial of intermittent therapy in those with newly diagnosed hormone-sensitive prostate cancer, intermittent therapy has been not shown to be inferior, but not shown to be non-inferior to continuous therapy for overall survival. It again has shown that those patients on intermittent therapy will spend about half as much time on hormone therapy as those on the continuous protocol, and with associated improved quality of life scores while they're off the ADT. So those were the sort of what I felt were 2 landmark trials. There are a number of other trials as well with similar findings from Europe and around the world. And publishing in that sort of time frame of 2010, 2012. So that, now nearly a decade since the publication of these trials that I've discussed, what's the urology world done with this evidence? Have we integrated intermittent therapy into practice? The table here presenting a summary of some of the international guideline panel's recommendations. They offer some direction on the role of intermittent therapy in current practice, but my take is that they certainly don't push its use. If we look at the NCCN and AUA in the M1 castrate sensitive prostate cancer space, really have moved on to say, look, ADT with treatment intensification is preferred for most patients with metastatic prostate cancer. AUA actually recommends against intermittent therapy in otherwise healthy individuals with metastatic hormone-sensitive prostate cancer. In the non-metastatic space, biochemical recurrence rising PSA, not suitable for local therapies or curative therapies. The guidelines groups do consider delayed hormonal therapy, but possibility for earlier introduction of ADT for those with a long life expectancy or short doubling time, high PSA. And if you're going to use ADT in this space, use intermittent therapy. This was a paper really looking to see what the use of intermittent therapy was in the real world practice. It's a SEER database cohort study from the US. So as with a lot of SEER database studies, limited by the accuracy of accessing that database. But in the cohort of 2,500 men with metastatic disease and just under 2,000 with recurrence disease, identified that intermittent therapy was used in only about 20 to 28% of patients in this cohort, and there was significant variation in use of therapy across different geographical areas of the US. So, a bit like just my trigger for this talk, my practice I'd seen in New Zealand was coming here, the intermittent therapy in contemporary practice appears to not be widely and certainly not uniformly utilised. So what are the big events since that time point in sort of late 2000s, 2012, is that the advanced prostate cancer landscape has certainly changed. We've seen major advances in survival with systemic therapies such as docetaxel and novel hormonal agents, both in the castrate-resistant, but also in the de novo metastatic space, but also then now in the non-metastatic but castrate-resistant space. The challenge we find for intermittent therapy is really that the evidence, the trials that generated the evidence for all these agents now had the agents given in conjunction with continuous androgen deprivation. So now in clinical practice, using agents such as abiraterone, apalutamide, enzalutamide, and even docetaxel, is that we're relying on evidence where they were all given then continuous ADT. It's hard to really consider intermittent therapy when we don't have that evidence for use of those agents alongside intermittent therapy. So has the horse bolted on intermittent therapy now that we've moved on with other agents? There's no clear trials published that I could identify that look at the role of intermittent therapy alongside these novel hormonal agents or chemotherapy. Is the data coming? Are there trials in place? This table was taken from a review article published in Nature last year, looking at the NIH clinical trials website. There's very limited active or recruiting trials when you look under the term intermittent androgen deprivation. There are certainly some trials looking at tools to try and extend the interval off ADT for patients having ADT, be it using stereotactic radiation or novel systemic therapies, including pembrolizumab. My own sort of look at the clinical trials or NIH website was looking under intermittent therapy, but also intermittent therapy with abiraterone or enzalutamide, etc. I could only identify a couple of planned trials that might suggest there's a future for intermittent therapy alongside these newer agents. This top trial here, the intermittent androgen deprivation for stage 4 castrate-sensitive prostate cancer, is an early phase 1 trial of intermittent therapy plus intermittent abiraterone in castrate-sensitive cancer. It's only looking to recruit 14 patients, and it's accruing at the moment. The paper down here, which caught my eye, but unfortunately is already closed, falling over without even recruiting a patient, was an intermittent hormone therapy with apalutamide. A final study that I just wanted to comment on that was presented at ASCO last year and caught my eye was the Restore trial. This was a trial looking at bipolar androgen therapy in men with castrate resistant prostate cancer. So it looked at men who'd been given abiraterone or enzalutamide and then were progressing. And so they were castrate levels of testosterone. They then actually gave them exogenous testosterone to bring them to a normal serum level of testosterone. And I think this really goes back to those early trials of Dr. Goldenberg and Gleave and Brukowski's lab work, where can you, by bringing the serum testosterone levels back up into the normal range, can you impact the tumour environment to then sensitise subsequent cell lines to subsequent androgen deprivation? So, in a cancer where they're progressing with castrate testosterone, despite then also being on Abi or Enza, can you buy yourself another crack at them with Enza or abiraterone by giving them a period of testosterone therapy? And I wonder if in the earlier intermittent therapy trials where we saw that the minority of men got themselves back up to normal testosterone levels, was that in part to blame for not seeing better improvement for a time to castration resistance? This was a trial presented at ASCO, was early stages, but suggested that there was an improvement in subsequent sensitivity to enzalutamide, but not in the abiraterone group for those who'd had this bipolar androgen deprivation. So to start to wrap things up there, the current data, if we look at intermittent therapy for advanced prostate cancer, the data to date show that the intermittent therapy we don't see as inferior to continuous therapy with any statistical certainty. Certainly, quality of life measures such as mental health, physical health, and sexual health favour intermittent therapy over continuous therapy. But in the current era, where early systemic therapy for hormone-sensitive disease, intermittent therapy is likely to be best suited more to patients with non-metastatic or perhaps low-volume M1 disease. And this is a schema taken from the same paper I've mentioned in Nature last year, and how I think I'd think about intermittent therapy going forward. Is you have a patient in front of you that consider androgen deprivation, and are they in the non-metastatic space or are they in the metastatic space? In the non-metastatic biochemically recurrent space, you'd initiate them on an androgen deprivation regimen for 7 to 8 months, and then reassess them at that time point for their PSA response, but also to see how they've tolerated ADT. If they've had no symptoms due to the ADT, an argument to then just carry on with the ADT in a continuous fashion. But certainly if they've had symptoms or impacting their quality of life with ADT, you can counsel them about the role of going on to intermittent therapy. There's some suggestion that this is better suited to those with a lower grade of disease. In the metastatic space, again, initiating and reviewing after 7 to 8 months of androgen deprivation. If they've got no symptoms, then they're perhaps best suited to carrying on with the continuous therapy with or without additional agents on top. But if they're getting symptoms and impacting the quality of life, you can, again, in the good or intermediate risk candidate, counsel them about the role of intermittent therapy. Really, that's the wrap up of my talk there. So thanks to everyone.